Thank you for the kind introduction, Dr. Ajay, a good friend of mine. And thank you, Dr. Mohan, and the entire Mohan's team for providing this opportunity to me to be here today. Dr. Arvind Gupta has beautifully covered a lot of things, which you see the standard of care, how to go evidence-based medicine, and what we need to do when we see a kidney-related diseases, especially we are leading in the capital of diabetes. I'm going to talk something very different. It might be like opening a Pandora box, but I usually believe that the real-world evidence is something completely different from what we see in our day-to-day randomized controlled trial, which has been very much controlled environment. It is like driving a car where they say the mileage is 20-25 kilometers, and then you drive it on our roads, you see it only at 10 or 15. So, role of NAC and taurin in reducing microalbuminuria, this is how nutraceutical might be helpful. So, just to go a little bit of basics, if you can see that when the chronic kidney disease starts, it never stops, continues to progress years, months, drop in GFR, increase in creatinine from stage 1 all the way to stage 5. Where do you hold them? Where are you supposed to hold them then to stop this kind of deterioration? You see that in KDIGO guidelines, previously only eGFR was calculated. So we have this G1, G2, G3. Now it has become very easier because most of the labs actually give you the eGFR, and it is easy to calculate, and it's easily available to make people understand on what grade. But in 2012, one important factor was added to this. That is, they added the albuminuria, the persistent albuminuria, micro, macro, and they said less than 30, 30 to 300, and more than 300. Now you grade it as G1A, G1, A2, A3. So this is how you grade it. If you can see where the yellow boxes are, that is in G1, A2 and G2, A2, and then you come to G3, A1 is the right approach where you need to catch this microalbuminuria most of the time. Coming to this slide was already been presented by Dr. Arvind Gupta. If you can see, the leading cause of kidney-related diseases today is diabetes. Then you have the glomerulonephritis, then various other causes including hypertension. But then diabetes is the only disease which has metabolic, hemodynamic compromise, and inflammatory fibrosis. This is the basis of having a chronic kidney diseases, and this is how it starts. So the oxygen-free radicals and advanced glycosylated end products, these are the forms the basis which activates the cascade of inflammatory markers, where you can see TNF-alpha, interleukin 1, interleukin 16, 18, and there are many others. And today all the researches are basically based out of this. How to contain these inflammatory markers, how to stop these cascades, where it creates a lot of other factors. So that's how it is. Then you have the extracellular matrix, then you dive deep into the pathology, and then you see that there is a glomerular sclerosis and tuberostitial intestinal inflammation, and then it goes progressing from one to the other. So what molecule are we talking about? When they came up with this trial to me, I was a real world evidence based kind of researcher where I only look at the real world evidence of how this works. So they gave me a literature. From the literature, just to present you this, N-acetylcysteine, this is a molecule which was first found in 1960s, and it came into effect in treatment into 1963. That means well before most of us were born in this in this current era. And then you see it was first used as a paracetamol poisoning. Even today we continue to use it, and it says that for the glutathione it is helpful in developing that, and then that is the deterioration. It is a direct scavenger of free radicals, antioxidant, decreases creatinine, is found to decrease creatinine, and lowers albuminuria, improves kidney function, relieves of inflammation, which creates the cascade. Coming to the N-acetylcysteine, now the next question comes at how long has these data been? We have been using this, how long? So if you can see in this European journal which was published in 2017, you see that retrospectively approximately 1.25 lakh CKD patients were put on these drugs, followed up for 10 years, and they found that NAC was associated with an 18% reduction compared to placebo. That means upward standard of care. Probably in 2017 we did not have adequate data to prove all these drugs which Dr. Arvind Gupta actually presented. Today it might be much different. But then even in those days, we see that this molecule has been there quite some time in usage. Similarly, in 2023, there was an article, again a 3-year cohort study in chronic kidney diseases where this molecule was used, and they found that it was significantly useful when compared to placebo when it was not affecting. The next molecule I am going to talk about is taurine. Taurine is a non-essential fatty acid, which amino acid which is there in the body. It is abundantly available. It was withdrawn from Amazon in 2021 because the FDA did not tell that that's a dietary supplement. But then the FDA subsequently said it is a dietary supplement, and it was introduced back in 2022 where you can purchase this over the counter. What happened to this is you can see this particular amino acids has a wide range of action in the kidney functions. In the vasculature, it regulates the blood flow. In the glomerulus, it is oxygen-free radicals which removes the oxygen-free radicals. In the proximal tubule, sodium cotransports, regulates taurine pool size and medulla. Normally, you do not need a substitution of this in a normal human being because it is abundantly produced by all the cells. But then in kidney-related disorders, you can see that the production itself comes down. So substituting these molecules have actually made a greater impact. So now we come to both of these sections. So we see one, the main tissue injury and the inflammation. It is a balance between an oxygen antioxidant and a reactive oxygen species, which is otherwise an inflammation marker. So this molecule is combined and available as a single pill. And how does it improve? It prevents the basal membrane, and it also prevents the podocytes from getting injured. So now we know the science behind what all this is. What studies do we have? We always say evidence-based medicine. What kind of evidence do we have to substantiate our claim? So we see that the single center study, which was a pilot study back in 2008. And then we have a 6-center nephrologist who did a trial on this, which is an RCT. And then you have the 9 diabetes center real world evidence, which Dr. Mohan was leading it. And that is what is being presented today in Mohan's Diabetes. It gives me a great pleasure to do that today. So the first one is published in KI Reports, Kidney International. So in 2025, and you can see that in this trial, it was a prospective multicentric randomized trial. Let's go into the details. So if you can see the nephrologists who are involved from north, south, what kind of diet you take, and you know from the START study that our diets are not very much different from the other people. Throughout India, we consume carbohydrates, less of protein, and that's what has been there in quite a long time in the process. So we try to see this trial, try to figure out what is happening in the north, south, west, and east. And then what this trial measured? It measured microalbuminuria, whether it is reduced. It measured the serum creatinine. Did it really make a difference by adding this drug? And it also measured the cystatin C, which is otherwise completely observed. And to calculate the eGFR, cystatin C plays a major role. And there are formulas using cystatin C to calculate, which is approximately, which is almost very, guideline-based ones. So what result did it produce? It produced overall the urine albumin creatinine ratio declined by 18.6% in patients whom we use NAC and taurine, and then 34% reduction in microalbuminuria and 17% reduction in macroalbuminuria in these groups respectively. Similarly, if you see the cystatin C, the overall cystatin C reduced by 21%, especially in NAC and taurine group. its median range to baseline, the two groups are also statistically significant. And similarly, you see the results of EGFR in patients who use these drugs. EGFR was preserved in most of these patients, and there is no further deterioration, slow and steady. In some of the patients, it's actually proved to be improving the EGFR. So that's how the study ended. And the summary of this study is 18% overall reduction of UACR. And there was a 34% reduction of microalbuminuria, and then you have 17% reduction of macroalbuminuria, which is quite whooping for a nutraceutical to perform. And then you have the cystatin C at 21% reduction, and then you have the preservation of EGFR even after 6 months of treatment. Another study, this is the first study, which is a pilot study, which was done again by Dr. Vijay Vishwanathan, two great doyens in medicine today we have here. This is a study initially was done in, it's a small pilot study. So it was done in 41 patients, and then it was 10 patients was in ACE ARBs, and then low protein diet. And again, when you substitute these drugs, it has found to be beneficial. And this is the trial which I was also involved in part of it. This is a real world evidence published in WJPSR in 2025. And you can see it was led by Dr. Mohan, and then 4 of the diabetologists from Chennai, then Kolkata, then Mumbai and Ahmedabad. And what did we see in this? We saw the overall reduction from baseline. There was 11.77% reduction after 90 days of initiation of this treatment. And then you can also see in CKD1, CKD2 and CKD3. Further to CKD3 we did not take it because there the kidney is already lost. So the next ideal thing to do in those kind of patients is directly get them to dialysis. So we did not try it in those patients. And we saw that when we use this early in the course of disease, before you can use any other standard of care, or along with the standard of care, it has found to be specifically effective in bringing down the microalbuminuria and the macroalbuminuria. So coming to the summary of this, NAC and taurin effectively reduces urine microalbuminuria. Stage 1, stage 2 is the right time to start this medication if at all you have to. And then in diabetic kidney disease, it is found to be extremely effective when all other drugs might or might not be contraindicated. So the summary, NAC and taurin can be used, considered as an adjuvant therapy on these patients. Microalbuminuria in 3 to 6 months time has seen a significant improvement. It can be twice a day or once a day depending upon how you want to place it. And there is one more drug which has been added to this, which is pyridoxine. It has been done for mostly patients who are in stage 3 and stage 4. So I think it has found to be a little bit more effective than that. So evidences are building towards the nutraceuticals usage apart from the standard care. There is no gold. The gold standard for any kind of treatment is what evidence based is. That is what Dr. Arvind Gupta has clearly told, all the 4 pillars. I am going to finish up with all the 4 pillars which sir has presented. So SGLT2, definitely yes. ACE, ARBs, and then MRAs and GLP-1s. And the last right side corners are expensive, the left side corners are cheaper, and this is being placed in the center as an additional tool which you can be used, but it might not be a standard of care, but yes, as an adjuvant therapy it can be used.